the children because then they shine. They actually want to live up to your expectations and they do well. So, under the theme of today, which is our opportunity and choice, we need to ensure that we provide the same opportunities of learning for all our children, no matter what disability they have. We also know this authorities that early intervention is the key to this. Why? Because early intervention actually taps into the at-risk infants and toddlers who have any kind of developmental delay. These services are then the children's needs in all the developmental areas like cognition, communication, gross motor, fine motor, etc. And this helps the child sit in the school and learn, sit in the school and socialize their tiffins, their utensils like your pencils and crayons with other people, and you learn a lot of interpersonal skills also in a school setup. So it is an ideal place for us to actually intervene. I'll talk a little bit about the process. I joined the company called Shaping Therapies, which was an organization that was founded by two people, and both of them outside the field of OT. One was a management, from a management background, Himanshu Joshi, and the other person, Manjari, is from a psychology background. However, both of them realized the sheer importance of occupational therapy, and they started the centers as well as they employed occupational therapists and put the therapy get-go. When I joined, I looked back at their process of the various schools. They were into the line of education and they had trust with the principals of the schools or the higher ups. And that's how our leeway or the way that we would get into a school system is you coordinate or communicate with different trusts. Yes. Okay, I think that was it. Okay, you coordinate with different trusts or principals of schools, the higher authorities that are involved in the schools, and you explain to them the need for occupational therapy for normal children as well as especially for the children who may be slow in learning and the school has a problem and is not able, to cater to that child's needs individually. We all know that we are in a country, overpopulated country, where our teachers are dealing with probably, somewhere between 30 to 60 to 100 kids in one class, right? So we have a lot of these slow learners who are not even being acknowledged, let alone time or extra efforts to. And we also all know that we are in India, a country where academics is given such a big preference, right? You are all in the South. I'm a South Indian. I know all our parents want all our kids to do really, really well in academics. And so then what happens to these outliers who are not able to catch up with the progressing population of kids? So when you do that, though, when you talk to the school system, is the situation that you can get into. Either the school invests in an occupational therapy wing or a center, or you can, come in with the school and share the cost, or you can actually put in the cost and then, on a profit sharing basis, you can take the center forward. On an operational level, how does the OT work? You can do traditional occupational therapy that happens in, settings either pre or post school. You can also do pull-out therapy services, which we sometimes do here. If there is a child who's extremely hyperactive, moving around, running around in the school premises, difficult for the teacher to handle, the child is brought to the occupational therapy center, can actually undertake therapy services and help him calm down, and then he can go and continue his, schooling. Also, therapists conduct in-class observations to see interpersonal relationships of the child to other children. What happens when he gets bored? What happens during transitions between one teacher and the other? What are the activities he likes and doesn't like? What if he doesn't like craft? Does he tear the paper up? So that then those issues can actually be addressed in therapy and then can therefore be generalized to the school setting and help with learning. training programs for parents and training programs for teachers to explain to the teachers what is ADHD, what happens in ADHD, what happens when the teacher is writing with the chalk on the board and the child with autism is hypersensitive auditorily and he is getting bothered by it. What can the teacher do? For the parents to understand that what are the activities that the parents have to do at home to then help the child settle, whether it's in the OT department or Maharashtra board, which you guys might have a Tamil Nadu board, and also understand national open schooling. So there are children who may not be able to give all their exams together in a regular or a typical school setting. They have the option of giving their exams either at one subject at a time or maybe two or three. Lots of flexibility is offered in NIOS schooling, which is a national institute that offers certification for 10th and 12th standard if your exams are given. And also important to understand is disability certification. So if you have children coming to you right now who have letter reversals and issues that later on do not get addressed completely, if they can get a learning disability certification or a disability certification, and they can keep the papers or the answer sheets that they get from school as evidence, they can use that later on to avail concessions from the school. So they can get concessions like having a writer, getting extra time for a particular subject, not doing as many subjects altogether. All of that can be achieved if you have evidence to then write to the board or the school authorities. Now coming to in the process, how is it that we see the children? Okay, so there is a school counselor who identifies if there is a child with a specific need, whether if the child is, so what are the signs that they look for? So if the child is unable to sit for the period of the school, the child is not writing despite multiple cues or attempts to write, so despite remedial efforts of the teacher, somebody's on mute. Guys, somebody's on unmute. Can you please mute? Okay. If the child is unable, if the child has any inappropriate behaviors like violent behaviors, aggressive behaviors, tantrums, the child is then sent to the center for an evaluation. A psychologist does an intake, which includes a detailed history of the birth of the child, the parental, relationship, what is going on currently at home. And then the child is recommended to have either occupational therapy or speech therapy or remedial teaching or all of the three at this point of time. We also have access to applied behavioral analysis and animal assistive therapy, also hydrotherapy at this point of time. However, that is then left to the discretion of the psychologist or the occupational therapist who's seeing the child. Behavioral therapy is also undertaken by the psychologist at the center. So basically, even if there are no other paraphernalia available to you, if you go into a school setting and you say, I want to start, at least the teacher can identify one or two or three cases for you that you can then evaluate using assessments that are available to us in our own field. Now, what are those assessments? We have sensory profile, which is available in the age of 4 through 14. Let me see if I can. Yeah, this is how it looks. This is the new sensory profile. It talks about all the sensory needs of the child and puts the child into 1 out of 4 categories. So either avoidant behavior, low registration, seeking behavior, so those kind of categories the child is put into, and the questions are provided for each different category. So this is auditory processing. Then we have visual processing, you have touch processing, movement, body position, oral sensory, conduct associated with sensory processing, and social and emotional responses, and attentional responses as well. Then you actually you score it And then the child is put into the 4 categories of seeking, avoiding, sensitive, or registration issues. Similarly, there is a sensory profile for a child who is younger than 35 months, which is close to 3 years. Younger than that, there is another sensory profile which is very similar, but questions that might be a little different because the child is not older. There is also a short sensory profile that is available if you do not have the time or the parent doesn't have the time to fill out the long sensory profile. You have short sensory profile that gives you the same amount of information. All right. Other than that, we have MChart, which is an evaluation tool that is used for autistic kids to determine whether autism exists or not in the kid. So, and it's a parent report. So this is galloping, random walking, you're jumping, one leg jumping, jumping over. All of that is included, and the manual talks about all of these in detail. If any of you need any resources, I can share that with the higher ups in your college, and they can send it across to you guys later whenever you need it. There is a Bury VMI which actually tests visuomotor abilities of the child and has 30 items. There is a short form as well that has 21 items that helps measure the visuomotor integration. We also have the intelligence measure with the Wechsler intelligence scoring scale. And the areas under that are verbal comprehension, visual spatial characteristics, the fluid reasoning with matrix reasoning and with figure weights, working memory, processing speed, visual spatial puzzles, working memory with a picture span, and processing speed that is required for a symbol search. Now, all of these are paper pencil free. So if the child is unable to write, you can still assess this if the child is able to sit and perform a task. Now, what do you need to do? Just 1 second. So what do you need to do with respect to outcomes? Now, after the assessment is done, you can determine which therapy to use. You can use sensory integrative therapy, an educational approach to therapy, like we do with learning disability kids, compensatory strategies for those kids who, are unable to perform despite sensory integration. And I'll give you examples of those as well. What do you do with the outcomes? Then you actually have to make sure that you document these outcomes, and you have to document the therapy process also well. Remember that you're in a day and age where we're in modern India, where lots of outcomes need to be documented, so that tomorrow there is a question that arises, you can ensure that what you did is written out somewhere. So whatever documentation system you use, if it's a SOAP note, your subjective objective assessment plan, or if there is any other documentation system that you are using at the current time, make sure that you document every single session that you conduct with your patients or your clients, whether they're adults, kids, or whoever they are. Okay. Why? Because then tomorrow when you look at a 3-month, end of 3 months or end of 6 months, you can look back and see subtle changes. Now, sometimes if there is an adult client, for example, and you've done ADS with a client or who has a stroke, client is still narcissist with dressing. But 3 months ago, he was not even able to pull the hand up, and now he is able to do a little bit of it. So one part of the task is being done. But on an objective measurement, on a film level or a Barthel's index, the client still remains narcissist. Those subtle changes are important for occupational therapists, and also to document to family and to sometimes third-party payers, sometimes doctors, to say he has improved. There may not be such a big level jump, but then same thing with children. We have a lot of kids who we try to teach jumping, and they are unable to jump at all, especially those with gravitational insecurity. But they're able to step down. And so that is something that needs to be documented, and we need to take pride in it because we've taught that particular skill to the child. And although the jumping part is not taken care of, there is some change that is seen, but that can only be evident if you write down where the child was and where the child is now, or where the adult was and where he is now. Now, use this documentation to promote yourself as an occupational therapist, also to promote the profession, to state that these changes happen because of an occupational therapy intervention only. Also, you can use this for research purposes. Case studies can be designed on an individual, basis. Contrasting therapies, like sometimes you can say a child with similar symptoms, one of them gets a compensatory approach, whereas one gets a sensory integrative approach, and you can see, which one shows better results. And of course, we understand extraneous circumstances. We are not conducting randomized controlled trials under laboratory settings, but we can, if there is documentation, it can definitely be used for research purposes. Also, effect of intervention and collaboration with multiple disciplines. So, for example, in our center, like I mentioned, since we already have access to a psychologist, a remedial educator, and a speech therapist, the effect of the combined interventions of all of us and the teacher helps us determine the outcomes of the children and their functioning in the school setting. So that is something that can be addressed. I will also mention that I'm not just saying this to say it. We have genuinely recently asked for two publications in journals. One of them being a case study and the other being a needs assessment of teachers to understand how to deal with kids who have these issues. If in a class of 30, there are 5 children with ADHD issues, how to individually deal with all those 5 children. So we've done a needs assessment, and both of them are in the pipeline, for publishing. So it's not only what I'm saying; we are definitely doing it, and all of you can definitely replicate that as well. So before we move on for the question and answers, I wanted to do a little bit of a case study to get an idea from you as to what would you do if there is a child like this in a school setting, or if you were in a school setting, however you want to play it. I just want to get an idea from you as to what kind of things that you would do. So the first, both of these are real cases, but the names have been changed for protecting their identity. Rajiv is a 5-year-old child who constantly runs around in class and school. He pushes and pulls his classmates during free time. He writes so hard that he tears the paper. And he performs activities only if he is in the mood. If he is held physically, he will scream, he will bite, and he will abuse. So he uses cuss words. If given activities of his choice, he will complete them, but he likes being aggressive at all. So anything that he wants to break or he wants to throw really hard. He loves the ball pool and he loves running around. So I'm going to escape from my presentation and come to the video. So any of you, what do you think we can do with Rajiv? Nobody? I'm sure somebody knows what to do with Rajiv. Come on, guys. There's no wrong answer. All right. So what we did with Rajiv was we met with the teachers, all of us. He was taking occupational therapy and remedial teaching. He was not on speech therapy because he was a child who could talk. So we actually sat down with the teachers from the school together and figured out things that we could do to help him sit in school and to learn. So the first thing we did was we recommended a weighted vest for him that he could wear that would give him the proprioceptive input and tactile input for him to not run around as much. Did this reduce him running around completely? Definitely not. But if he would run around every, say, 10 minutes, now he would do it only once in 20 minutes or once in 25 minutes. Number one. Number two, we started using a visual board for this child. So just for Rajiv, there was a visual board that was placed inside the classroom that said no leaving the class, or what good behavior meant. So good behavior, there were pictures and there were words that said sit straight, hands folded, look at the teacher. And so 3 or 4 such strategies were written out on visual cards and hung right where he was sitting. Other than that, in occupation, so this was done at a school level. Also, he was given a busy vest. So there was a board type situation where he was given a zipper and a toy that could be tied, run around. So that when he was distracted and he was bored, he did not get up and hurt somebody else or push somebody else. He just sat with his busy vest. So these were done at classroom level. In occupational therapy, he was given sensibly integrative, therapy using all the ball pressure, ball pull, the swing, running around, obstacle keep. He was asked to write only superficially on the clay. We also tried and used eggs with him, that he had to pick up an egg and place from one place to the other so that he knew how much pressure he was exerting. And we used a token economy with him to start working on the activities that he may not have liked himself, meaning he did not like. No? Okay. All right. And if there are any other things that you want to add, please go ahead and you can put it in the chat box and we can talk about it after this. The next is a case of the opposite. So this was a child with ADHD features. Neha is a 3.5-year-old, very shy movement class because I'm sure she has some gravitational insecurity that is making her very uncomfortable with movement, and she has difficulty holding the pencil and writing. So anybody want to tell me what kind of things we can do with this child? Come on, guys. Somebody can at least unmute and tell me one thing. There's so many of you. I'm sure you all are very, very good therapists and been working with such kids and know what to do. I'll start calling names now. All right. Okay. Let me just go ahead and tell you what we did with this child. With Neha, what we did was we started slowly introducing her to movement and we kept her therapist stable so that when she formed a rapport with one particular therapist, we started with things that she really liked. She loved playing with the ball, but in sitting. So slowly we pushed the ball a little bit further away from the point that she was sitting. Then we told her to do it in kneel standing, then in standing. And even then she was a little scared, but she was able to at least handle that well. She had a little bit of low tone, so we put weights on her and had her do exercises generally. We also, spoke to the teacher again with the teacher and the coordinators to ensure that the transitions between teachers was explained. Who was going to leave and another teacher was going to come. At home, sharing of tools, sharing of toys, and slowly, right now, she's at a point where she's actually able to comfortably come to school. She still has a problem with strange people. So if there is a new teacher who comes in ever, or if a new therapist is taking her session, if her primary therapist is not available, then she does have a little bit of an issue, but she's settled down really, really well. Okay, so we do Q&A now, and the references, like I said, can be sent later to the to your teachers, and I can get them to you if you have any specific requests. Thank you so much for your time, and we'll open it up for questioning. Any questions? What kind of assessments do you use?
Students, please, we can ask you questions. If you have any doubts.
Yes. I just had one comment that said having a shadow teacher for okay, so having a shadow teacher for Neha, yes, that's a. Much yeah. So Namita, yes, you are right. Having a shadow teacher is something that we had also recommended. However, I will tell you that here in Bombay, getting shadow teachers is very difficult, number one, and two, very, very expensive. So that is something that definitely is we would make, but it's not very easy to avail that recommendation at this point of time where we are. And therefore, we try as much as possible for the actual teacher to be involved. Now, in Neha's case, thankfully, she's in a younger, smaller grade, so there are two teachers in class. But, yes, Namita, that was a very valid point. So, what kind of assessments are you guys using? Assessments at all? Okay, academic performance of rating scale. Yes, great. So if you used, yeah, Namita, the OT screening test is also fine, but if you can use objective assessments, what that does is it adds value to what you are presenting to any other person. So if you're presenting to a teacher, school setting interview, that is also a good one. So if you're using those, make sure you use those objective assessments so that when you're talking to a teacher or a principal or any other person, you have those assessment results that then objectify what the child is doing. Because when you're subjectively explaining, which although is important, we need the numbers also that can then give weightage to what you're saying. All right. Anybody have any questions at all? By the way, I don't know if all of you know that in the US, no child can be asked to leave the school or they be denied an admission in school. So in the US, if you are residing in a particular area, so for example, say you live in, I know one place in Chennai, okay, Valsarvakam. So say you're staying there and there is a school in Valsarvakam which is the government school there. The no child in that area can be denied schooling in that school from the government, no matter what disability they have. So if they have one second, I'll come to you. If they have learning disability, if whatever disability they have, including physical disabilities, mental retardation, they cannot be denied schooling. And so every single school has a small little parallel center where they have cases of, say, mild mental retardation. They will include them into regular schools for sport activities or for craft activities, and then do the educational part of the schooling separately. So we also need to employ some kind of methodology similar, because we don't have a lot of special schools available for our autistic kids and ADHD kids. For MR kids, there may be, but because the autistic and ADHD kids have so much diversity, one child is doing this and trying to close his ears, the other one is seeking auditory behavior. So it's very difficult to have one system or one size fits all. We need to make sure that we can make schools such places where everybody or a diverse population can all learn together. It also sensitizes our neurotypical or so-called normal children to interact with these kind of kids, because tomorrow they are going to be holding positions everywhere. So our regular so-called neurotypical kids also need to know how to interact with them and understand that there are sometimes idiosyncrasies that may come around. Answering the question of how do we reduce self-harming behavior in a school setup. So multiple things. Behavioral interventions work. We have psychologists who work on interventions, explaining to the parents and the teachers. Token economy. In that case, also you can have either a shadow teacher or a buddy. Okay, in school, sometimes in older kids, we can have buddies. So what we do is we have, say there is a very good child in class, a little bit older, a little bit wiser. We put that child along with a child who has a little bit of an issue, and we say, you guys are buddies and you have to help each other out. And it really works well, okay? Because generally, children are brutal nowadays with respect to teasing or hazing, but at the same time, they're genuinely, some of them are caring enough to actually want to help, their counterparts. In fact, we have a child who has a little bit of, autism, mild autism. He another child in his class and helps that child out significantly. So that also can be something that can be done. So in self-harming behavior, depending on what self-harming behavior it is, OTs can work on specific things. So if it's biting or if it's hitting, then with ABA, we can reduce those behaviors and check antecedent. Are there any particular guidelines for including schools like classroom strength? Unfortunately, no. In India, there is no guideline per se because there were no inclusive schools only to begin with. Now, and that too, you all know that schools have the right to deny admission to a child here. So, say a child is there in school and they have tried, and in 3 years nothing is working, the school can very well say, please take your child and leave, which is a sad state of affairs. And therefore, I'm saying that we need to start getting into school so that this doesn't come. I can very proudly say that at our center, most of the children who have come in with significant violent behaviors, ADHD behaviors, have still been able to at least be retained in school. Pure, not because we've begged, but because purely the children have showed behavior that is okay enough to be handled in school. So I'm not saying everybody has improved because that would be a lie, but most of them have been able to at least sit in school enough to be able to, carry out the activities. So the Achu, no guidelines per se as of this point of time. How can we develop self-eating behavior in a school setup? Okay, so in this also, Gifty, what helps is your buddy system helps. You can also form small groups. So in higher classes, we have children who are in 6th grade, 8th grade as well, right? So in those, what we do is we pick out 2-3 kids who are going to be good friends with this child, and we actually make them sit and eat tiffin together. Everything we try and make it more structured. So mostly what happens with autistic and ADHD kids is that they don't know what to do, they really don't know what to do. So if there is a transition period, teacher has not put them anything, the recess time, free period, that's where they have most issues. So we actually design then a system where they can they have structure to that also. So even tiffin time is structured. Open tiffin, eat your tiffin, wash your hands, drink your water, walk around the corridor. So that also can be written out. Now, with respect to self-eating behavior, we first need to teach that skill in an individual occupational therapy session as well, which includes everything. Your scooping with spoon, your breaking if you're eating a roti or a dosa, your drinking water from a sippy cup. All of that will need to first, the skill development will have to happen, and then the imitation behavior can happen during school time. Also, Gifty, what we can do for recess time is definitely have the therapist visit. So sometimes we do this where we do feeding interventions. Say the therapist visits and introduces maybe a crunchy item or a soft item which the child is not eating while they are in a social circle, and sometimes that helps. So these are all strategies that are a hit or miss. Sometimes they work really well, sometimes they don't, and then you have to be more creative. How can we develop board copying among autistic kids? Okay, so what we do for board copying is when we have a lot of children who have copying issues, if we've tried again at an individual OT level of copying and it is getting very difficult, we ask the teacher to give them printouts of what they're going to be writing on the board, so that they can still copy. The expectation is still the same, but at least they don't have to copy from a long distance. They can copy from a printout that is available to them close by. Or we can also give them the subject matter beforehand so that they copy, but when the teacher is writing, the last answer can be copied, or only the questions can be copied and break it into pieces according to that. How to control binge eating issues. Madhu, you'll have to explain to me what you mean by binge eating. Like, do you mean binge eating on being like eating only particular kind of things, or eating intermittently more than normal, or eating junk food? So, Madhu, if you can explain that, I will answer that question to you. Actually, Uma, you have my mother's name. My mother's name was Uma Maheshwari. So, how do we handle behavioral issues? So, token economy works really well for behavioral issues. The child is showing good behavior, you can show that. Visual boards work really well for behavioral issues as well. So show them what they're not supposed to do. Like today in the morning, we had a discussion on a child who is a proprioceptive seeking child, otherwise fine, but she will go and push people, and she gets very happy with that. So what we decided was to Again, ABA analysis, so antecedent behaviors, we know the antecedent, she's really excited and happy when she pushes somebody. So what we do is we change emotion. So we, show her either an upset or an angry face. Don't give her too much attention because sometimes it is done for attention. You show visual cards that says no. And also most important, what can be done instead. So the moment you say no to a child who's chewing a ball, well, okay, now I'm not chewing a ball. Now what do I do? So then you have to either give them a chewy toy or something that is okay to chew on. So we in the center sometimes we'll have apples and we cut apples and give the child for biting. For behavioral issues like pushing, okay, don't push, but you can tap. So you can tap on the shoulder. And every time the child taps, you either take the hand and you actually do tapping. And every time the child taps, you can give them a star. Most children understand stars or ice creams or whatever you want to give on their hand because they love that positive reinforcement, that adulation that they get. So every time they do some good behavior, make it a party, like actually clap and throw a big party, verbally, so that they know that this behavior is what I need to do more of and is encouraged more. How echolalia disturbs academic performance and does it disturb others? Yes, two very good questions. So echolalia does disturb, or not only echolalia. Sometimes I have a child who is a little higher functioning autistic child who knows answers to the questions already. Especially in math. So sometimes what he will do is before the teacher answers, he will actually blurt out the answer multiple times. And that affects the other children also who are with him because they are trying to learn and they are also trying to answer. So in those cases, then individually it has to be talked out with the child and the teacher. And what we do then is this child that I'm talking about, we give him 2 extra sums to solve in that intermittent time. So then he is interested in doing those, and we tell him that if you do 5 on paper, then you get a star. If you're answering ones on the board, then that is not going to help. So that works. Are there any pull-out programs at this point of time, Soumya? No, not that I know of. I don't know of any others, but I will tell you in Bombay, lots of schools have started hiring occupational therapists for sure. Recently, a junior of mine has been hired at Orchids International School. Another junior of mine has been approached by another school. So, OT in school systems is increasing, at least in Bombay for sure. And, you guys can definitely work on that at your end as well. Eating pencil and paper. Again, binge eating, is that what you meant by? Okay. So eating inappropriate objects, here, if it is a safety risk, you have to make sure that there is somebody like a shadow teacher or somebody with that person because it's a big safety risk. Secondly, you have to start giving the child something edible that they can chew on. Again, making sure. So you tell the child the pencil and eraser is not to be chewed on. So with a visual strategy that says a big red no. But instead, what is to be chewed on, you'll have to give the child. And along with that, of course, your protocols that you can follow. I mean, we use a lot of protocols. We have Wilbarger that we use. Sometimes we have oromotor training that we use to reduce the need for the oral seeking behaviors. We also give them chew toys or chew lockets that they can keep with them and use. Instead of chewing on paper and pencil, and again antecedent. So if you know that the child is going to do it beforehand, only reduce the probability of that happening. Especially with pencil paper, the child needs to be. Whenever there was an issue, they used to say we are not going to accept you. Now they're actually accepting such kids, and that itself is a big step, in the right direction. Now, with respect to inflexible school curriculums, you have to sit down with the higher authorities and explain to them that certain leeways have to be made for those children because otherwise the whole system is moot. Meaning, the child is in the system, but you are not catering to their needs, so it doesn't make sense to keep the child there. Having said that, I know it is not very easy because this is not the first school setting that I have seen. There are other schools also that are not even open to the idea of allowing, diverse children or making their curriculums flexible. We also have to be very, very aware, guys, that it is a big brunt on the school teachers. Okay, the school already, typically developing children are getting extremely over smart and answering back and being more. I think active than before. And on top of that, they have, like 30 to 60 kids in a class. And on top of that, now they're asking them to be, to have flexible curriculums and to offer extra help and to offer, visual strategies and all of that to our kids who are not neurotypical. So it takes a lot of, effort. It is a lot of effort on the part of the teachers as well. But the good thing is that we are here to help the teachers. So you can do even in services in schools for teachers, even if you are not, beginning an OT setup, to explain to them simple strategies that will make their lives easier. Like, if you can do a simple, for example, if there's a busy board and the child is given a busy board, it makes the teacher easier. You don't need to, keep going to the child and explaining to the child all the time. Another thing is sometimes I've even done, not a very good way to say this, but when you train dogs, there are these clicker buttons that you can use. You can use those to get attention of a child. Sometimes even a bell you can use to get attention of a child. Is there any diet to be followed for kids due to their GI problems? There are many dietitians and nutritionists who claim to put children on low gluten and low, yes, Achoo, I'll come to. Low gluten and low sugar diets that help with kids with autism. We don't have an in-house nutritionist, and we have not, yet come across anybody who has gone to a nutritionist and come up with a specific set of instructions. So, Amy, I don't know. To answer your question, I really don't know. But I do know there are lots of homeopathy doctors also in Bombay. There's a famous one who claims to help with socially inappropriate behaviors with homeopathy medications. And similarly, there are nutritionists also who have designed specific nutritional programs for children, and they tailor make them for the children as well, to deal with specific issues. But I don't have experience with either of them at this point. How can we handle meltdowns in class? Again, ABA works really well for behavioral issues. Okay, so like meltdowns, your chewing things, your aggressive behaviors. So one, we need to figure out what the antecedent is. So if the antecedent is that the teacher didn't pay attention in class, or the teacher, so this can be achieved through observation in class. So you can actually go sit with the child, in the class and see what they're doing. And sensory meltdown. Yeah, so then pull-out therapy can happen in case of sensory meltdown. You can pull the child off of class. We also have a small little, we have in one of our centers, we have a snow regulated. So we are available for the child, but we don't guide any behavior. The child is able to actually, look at lights and kind of settle down and, crash into bean bags, throw heavy objects around. It's a safe place and it's dark. They can make it lit if they want to. And that is also available, for a sensory meltdown type situation. All right, I think we've answered most of the questions. I hope it was an informative session for you guys. If there are any other questions or any other specific requirements, I will be available to send the information across through your instructors. But they're all proud OTs and they should be so continue the profession forward. I'm very happy to be taking this lecture.
Yes, ma'am. Students or therapists, do you have any more doubts? Students or therapists? Okay, now we end the program. Thank you, Dr. Kavitha, for it was an excellent presentation. Hope our students and therapists would have flourished with the knowledge which you have shared, your experiences now. And also thanks for accepting our request within a short period of time. And it is really eye-opening, especially in inclusive schools. As we said, the parents' choices to accommodate with the schools, mainly in the inclusive schools. So as an occupational therapist, it is our responsibility to provide them with the opportunities to adapt with the environment, especially in the inclusive schools. And once again, I thank, I also convey our thanks from our principal, Dr. Arun Kumar, and staff and students from Kavitha College of Occupational Therapy. Thank you so much.
Thank you so much. Best of luck, guys.
Thank you, ma'am. Thank you, ma'am.